So for those of you guys who have worked with me, you know that I love GI bleeds. It's one of the few things that I'm still scared of in emergency medicine. I've had very bad luck with GI bleeds. Somehow all my GI bleeds seem to be poorly. So I just don't want them anymore. It's just really, really scary. So these are the topics we're going to push through today. We'll talk about the causes of upper GI bleeding. We will concentrate on varices because, in my opinion, this is the worst one that I really don't want to see. This is the one that everybody dies of. We'll talk about pathophys, how to make the diagnosis, and then some treatment modalities as well. These are the causes of upper GI bleeding that we're going to go through: malaritis, esophagitis, gastritis, PUD, AV malformations, gastric cancer, some foreign bodies that can cause bleeding, and then varices is again what we're going to concentrate a fair amount of time on. So malaritis tears, you see these all the time. This is a person who's like retching, and then they cough up blood or they vomit blood, and that's why they come to the ED. It's pretty much just a tear of the mucosa. It's pretty self-limited, not very much to do for it, but I understand it's scary for the patient to be vomiting and then see blood. I can understand why that would be scary. Basically, treatment is stop the vomiting. Give them antiemetics, let their GI tract cool down, and it'll just heal. Remember that the GI tract proliferates very quickly, so it's going to heal itself relatively fast, and there's not too much to do for it. Gastritis, it doesn't penetrate the mucosa like PUD does, so we see a lot of it. I read this one paper that said that it's not benign. 6% require surgery, 1.9% mortality, and even higher mortality in older people. I think there might have been bias in this paper, right? It's written by surgeons, so they concentrate on certain pathologies, the only ones that they were called for. But in my opinion and in my experience, I believe it's lower than that, but this is what one paper said. Common causes for gastritis: drugs, alcohol is probably the most common one that we see. But just think about that when you're seeing your patients who are drinking and coughing up blood or vomiting up blood. Treatment: remove the trigger, all right? Take away their alcohol if they're in bed, 17, don't let them drink while they're in front of you. GI rest, encourage a good diet, nice healthy diet, which, you know, we have patients all going to follow. And then your GI cocktail of H2 blockers, PPIs, and Maalox to help calm down their GI system. And hopefully it just all resolves after that. Next one up is your infectious gastritis. This is the bloody diarrhea slide. Salmonella, Shigella, E. coli, specifically the H7O157 type, Campylobacter, Yersinia. If they're taking antibiotics, then consider C. diff and E. histolytica. I read that one paper that was interesting that said there's another bug that is associated with antibiotics-associated diarrhea, but it's often not bloody, and that's one way to tell it apart from the C. diff. Of course, you have your non-bacterial diarrheas also, with norovirus being the most common type. You see in the news all the time that like norovirus hits a cruise ship and everybody on the cruise ship gets diarrhea. Sounds like a horrible place to be out at sea with everybody having diarrhea on the boat. There's 5 subtypes of norovirus, and it can be spread in so many different ways: fecal, oral, contaminated food, person-to-person contact. It's really, really, really easily spread. Your diarrhea lasts for like 1 to 3 days, and hydration is probably the most important thing, right? You need to put fluids in as fast as they're putting fluids out to keep them from getting dehydrated. There's no agents to help fix it, so it's really just supportive care. And one thing I read that I thought was interesting is that people with blood type O are more susceptible to norovirus. And I tried to look it up and see why, but I couldn't find anything on it. If anybody knows, I would definitely be interested, but I couldn't find why that was true. And then, of course, to round out your top 3, rotavirus and adenovirus. I'm sure you guys have definitely done your fair share of peds and seen your rotavirus season and seen all the diarrhea from that. Treatment is generally self-limited, although I have to say when we trained, we gave all these bloody diarrheas gram-negative cover. But that's changed over the years. The only one that's really sometimes you give antibiotics to is if it's C. jejuni, where they get better when you give them antibiotic coverage. It used to be that we gave them either Bactrim or some other gram-negative drugs, but now they switched to Azithro, which it was due to very high resistance rates. I think they said up to like 30% resistance to the gram-negative coverages. If they've used antibiotics recently, then C. diff is probably on your list. And for that one, you want to treat with metronidazole, PO vancomycin. Remember that vanco is not absorbed in the GI tract, So it just goes through there and just eliminates the C. diff very nicely without causing any toxicity. And if you have E. coli, the one that makes sugar toxin, you don't want to give them antibiotics because that causes HUS and can make your patient much, much sicker. You want to definitely avoid it for those guys. I think without a school culture, you're probably not going to know any of this. So you have to guess and do your best job. Peptic ulcer disease is the most common cause of GI bleeding that we see. I would say we see it on a daily basis. I can't remember a day that goes by that you don't see it. Somebody with a GI bleeding from peptic ulcer disease, or at least like upper abdominal pain. It could be in the stomach or the duodenum. And for some people, it's painless. They don't even know they have it. They just show up with symptomatic anemia. And then when they get scoped, they're found to have a lot of ulcers. So it doesn't have to be painful. Offending agents, one of the biggest ones is NSAIDs. How many of your older patients are on aspirin daily? That stops you from producing the mucosal barrier in their stomach and leads to peptic ulcer disease. I found 5 times more likely to get it over the age of 50, which I think is pretty scary because all those people are on aspirin for their ACS. And people with high acid production are also more likely to have it. And that's your people who have very stressful lives, like some people here, and Zollinger-Ellis syndrome, which I've never seen a single case of, but these people come in with like tons and tons of ulcers all over their stomach, all over their duodenum. Biggest offender is probably H. pylori. When people get infected, they're much more common to have peptic ulcer disease. Complication of peptic ulcer disease, what do you guys see here? Good, area of the diaphragm, both sides. Often more likely to be seen on the right side because the liver sort of outlines it. But did everybody also see, or were you able to see the pericardium being silhouetted? This is air in the pericardium as well. Probably the air of the diaphragm snuck up through the cruce of the diaphragm where the aorta runs and got up to the heart. Symptoms, burning, epigastric pain, super common. We see this all day long. But like I said before, some of them is asymptomatic. If they're breathing briskly, you may see hematemesis or hematochezia if you have a very fast transit time. And then if you have a slow transit time, you're more likely to see melena as the bleeding gets bigger and more heavy. So let's talk quickly about H. pylori. This is one of the biggest problems that we face in emergency medicine for PUD. It's a gram-negative microallophilobacterium that lives in the mucosa of your stomach and lives in the mucus layer. There's actually a blood test for it. There's a stool antigen test for it. There's a urine ELISA test for it. And the breath test I thought was kind of cool. One of the things about H. pylori is it has urease in it. And what that does is it splits urea down to CO2 and ammonia. So if you give them radio-labeled urea, then they break it down to CO2 and they can breathe it out. You don't have to do anything invasive to test for it. That's the breath test. Gold standard is still biopsy, right? All those tests are nice, but you need to biopsy to prove it's there because it lives in the mucosa, in the mucus layer. Treatment, you guys do this every single day. PPIs, H2 blockade, antacids, maybe superphate as a coding level, and then triple therapy for H. pylori. Change your diet. Don't eat such bad food. Don't eat like spicy red stuff. And then smoking cessation, which I really strongly recommend. Triple therapy is omeprazole, amoxicillin, and chlorifra. Some people add bismuth onto it. And if you're allergic to amoxicillin, penicillin, then you can give them metronidazole instead. I actually read a couple different papers that said that smoking is super important in PUD. I really didn't realize why, but now I see there's so many factors in there. It makes you secrete less epidermal growth factor, which slows your gut healing and slows your mucosal level healing. There's less gastric blood flow to the stomach, bringing in antibodies, bringing in healing materials. It releases histamine. You guys know we give histamine blockers for GI bleeding and for peptic ulcer disease. It causes pepsin secretion, which breaks stuff down. And then it also decreases the mucus level, and it causes H. pylori to proliferate. So I didn't realize that smoking played such a big role in peptic ulcer disease. I thought that was kind of interesting. Other causes of bleeding, esophagitis and GERD, AV malformations that get eroded into and burst, that would cause very large bleeding. Gastric cancers, some of the lowest H&Hs I've seen have been in gastric cancer, where they just bleed continuously over time. And then, of course, foreign bodies and trauma. Sometimes foreign bodies that you can ingest can be sharp and just rip up the GI tract and cause other troubles. So what kind of foreign bodies have you guys seen? I found this very entertaining part of our practice to see what you can find in the stomach. So this is going to be an interactive part of the lecture. What do you guys think? Excellent. They're bridged from their mouth. Teeth are sharp. They've ripped up the stomach. What other things have we seen down there? Carpet staples. These are the long staples. They use the whole carpet down to the floor. Why you would ingest these, I am not sure. I would not urge it. This is a kid. You can see the growth plates are all open. What's that one?
A clipper?
Somebody's earring. Mom's earring. Took it right out of her ear and swallowed it. Straight pin. Pretty sharp on one edge. Definitely risk of perforation. They're gonna have to go in and get that out. Needle, no head on it, so you gotta know your anatomy of your devices. This one actually perforated through the duodenum and was outside the GI tract when we saw it, led to a micro perforation. They had to give it a washout. Their stomach was all totally inflamed. They were peritonitic, really bad case. It was fully outside the body, not even sticking outside the stomach, sticking out a little bit. No, it was all the way through and outside. So if you're going to ingest pins, this is what you should inject. Safety pins. So you have this covered. This covered. Safe. Ingest them closely.
Some good first sounds.
Sheet metal screw. Remember, wood screws have the angle top. Sheet metal is a flat.
Pearls.
Mom's bracelet off the wrist. Oh, this is actually a case I saw. Who recognizes that dollar? This is a guy who got caught cheating in dominoes, and rather than have his friends call him out, he stuffed it in his mouth. Great trip to the ER with every domino in.
Yeah, it's done with you.
And then, of course, we don't have to always ingest them. Phillips head screwdriver. Easily grabbable, as I said, bob sticking out. Which one was this? Oh yeah, razor blade. This is actually really common because prisoners want to get out of jail, so they'll ingest a razor blade, but they'll tape it first. But the thing is that the tape doesn't show up on X-ray, so all you can do is wait for it to pass. It's a free couple days out of prison for prisoner. This one you have to recognize.
Yeah.
So this is a button battery, and you know it's got that double ring sign. All right, the outside is more dense than the inside. This is a tough one. Took me a while to figure this one out. I think you can see it, although the light's not great in here. So it's not the clips, it's the cucumber that's in the bottom, which you can see here. We've seen a lot of crazy stuff in our job, man. This one's a little more obvious. It's a little more dense than the cucumber. It's synthetic. What's that one? Toothbrush. With the travel case, you don't want to go home without it. And if you don't like a regular toothbrush, there's always the electric toothbrush. I think construction is amazing. Just a battery, a little engine, and then a spinner. And then it just a little bit off center, so it vibrates. Drinking cup. I'm not sure how that one happened. 1 in a million chance. I don't know. This is a good fast track case we had many years ago. This guy came in for belly pain, but was Spanish speaking, and the physician didn't use an interpreter and got sent home. And he came back the next day going, I don't know why he didn't examine me, but they got an X-ray and this is what they found. That's right, it's the garden sprinkler. Spray can, perfume, or deodorant, actually deodorant. And this one's a famous case many years ago. If you ask me the story, I'll tell you when we're drinking. 2 bottles, not just 1 but 2. And then my favorite case of all is the one Buzz Lightyear. Way to please. Good job, Carla. You know your cartoon. All right, so stick around for the next part. Is going to be all about varices, and that's my favorite form of babysitting. So It's usually caused by cirrhosis and seen in people with hepatitis or alcohol ingestion. It leads to portal hypertension, which makes your pressures go up in your liver. And therefore, the blood gets pushed from your portal system into your venous system without going through the liver. Plus, the liver is not super effective, so we'll talk about that more later. Anytime you see a person with cirrhosis and they're altered, it's often because they had a large protein load ingested. So what kind of protein do you get? It doesn't have to be steak. It can be just straight up blood, right? Because blood has globin in it, that's a protein. And that could be why they're altered. So anytime you see an altered alcoholic, think GI bleed, check the DRE to make sure they're not bleeding. 60 to 70% of people with varices, they're gonna rebleed after the time you see them. So it's a pretty chronic disease that they're gonna come back for over and over and over again. 30% go to surgery, and 1/3 of upper GI bleeds that die are gonna die from varices. So causes of cirrhosis, this is getting into the advanced liver problems, but Hep B, Hep C, alcohol is a toxin for the liver. We'll talk about that a little more. Other less common ones, schistosomiasis, Wilson's disease, too much copper, hemochromatosis, tuberculosis, and then Budd-Chiari syndrome. And I always have to look this one up because I never remember what it is. That is hepatic vein thrombosis, plus or minus portal veins as well. And in 50% of people, there's no cause, nobody knows why it happens. Protein C, protein S deficiency can make you hypercoagulable as well. For some reason, it happens a lot in people with malaria. I think it might be due to slow flow in the liver due to all the parasites. And then it leads to this really, really bad ascites where you get very, very large belly. So what happens in cirrhosis? Well, the liver gets attacked by this toxin and you produce a lot of endothelin 1. That leads to secretion of, that leads to growth of the epithelium, which narrows the sinusoids and makes it harder for blood to get through there. And then pressures go up. Nitric oxide is also not synthesized, which is the vasodilator that makes pressures go down. So that, again, your pressures are going up. As pressures go up, the hepatocytes grow more and they lead to sinusoidal thinning or narrowing. You get collagen deposited in the space of dis, which I don't remember what it is from med school. I know I read it once or twice, but don't know. Then you have compression of your venules due to regenerating iron. That some parts are regenerating, they push on other parts, leading to decreased blood flow yet more. And then perisinusoidal block by portal inflammation, portal fibrosis, and necrosis. So everything is causing the path that blood travels through to get smaller and smaller and smaller as your cells are getting killed off as well. This leads to portal pressures going up and being pushed away from the liver. Blood is being pushed away from the liver. That's the overall problem. So what happens, the liver is destroyed, the architecture is destroyed. Internal flow in your gut gets switched from portal to systemic, and you get these collaterals develop. And where are the collaterals? We'll talk about that in a second. But as these collaterals get more and more dilated, they have more of a chance of rupturing. And this is where the big problem is, because your liver is also responsible for making clotting proteins. If it's not making clotting proteins and leading to rupture, you can see how that would be a double problem. And then, of course, your liver also takes toxins out of your blood that may make you go into encephalopathy, which we can talk about Child's classification in a little bit. So your gut has two circulations. I'm sure you guys all know this. Your portal circulation and your systemic. When the portal circulation pressures go up, it switches and moves to systemic. Places where they're connected are the esophagus, that's your varices. Rectum, that's hemorrhoids. And also around the umbilicus, which gives you your caput medusa. Those are all the three places where blood gets transferred from portal circulation to systemic circulation. So Child's classification started out in Michigan in 1964. And it was only the Child's Turcotte, but then this guy Pugh also added in some other things. What he did is replace the nutritional status with INR because it was just easier to do. And now you ended up with your classification system that we see now. And what this classification does is it actually gives you a life expectancy and also a perioperative mortality, which I think is really interesting because it's not something that we really use in the ED, but we're asked it all the time. So how do you diagnose varices? Well, the gold standard is still endoscopy, but some people may not be able to tolerate it. And I thought it was pretty cool for the stable patients. They have this pill camera now that you can ingest. It takes pictures going down, and then they just recapture it later on when you're done with it. I don't want to be the one to capture those things. You can use ultrasound to check it out, either transabdominal or transesophageal to look at flow rates. Endoscopy and then CT and MRI. You can also calculate flow rates from that. Risk stratification is based on variceal size and variceal flow. And if you're over 20 centimeters per second flow, you're at risk for rupture. This is as they're starting to get bigger and your pressure gradient is higher. If you're still drinking, also at a risk for rupture. And they have something called red whale marks, which look like corduroy. There are multiple varices in a row. If you have red whale marks, you're also at risk for rupture. They then looked at the platelet count to spleen diameter, or PSDR. Again, they used ultrasound to figure out the size of the spleen. And if your PSDR was over 909, random number, but you're at risk for developing varices and then developing rupture. All right, and then also finally, if your hepatic pressure gradient is over 20 millimeters of mercury, you're at risk for rupture. Treatment, if you're not bleeding and you have varices, you want to do whatever you can to decrease the pressure gradient. So you can give beta blockers, non-selective beta blockers that will decrease your cardiac output and decrease your shear forces. You can give splanchnic vasoconstriction like somatostatin. Nitrates will also vasodilate you. And then, of course, behavioral modification. Stop drinking, stop doing the bad things that you're doing that cause it. I found it interesting that they said in the last article I read that there is no drug indicated for variceals and for GI bleeding. It's all off-label use. I never realized that. I thought it was just kind of interesting. Treatment, if they're at risk for airway loss, you want to intubate them. IV fluids, blood if you have it. As soon as you see these variceal cases, you should type and cross them for 6 units right away, because there's a good chance they're going to need it. FFP and vitamin K to reverse the coagulopathy. A lot of people recommend, or a lot of papers recommend putting in an NG tube to take all the blood out of the stomach so your aspiration risk goes down. Some papers I read said that you're at risk for rupture in the variceal, so you shouldn't do it. I think it's sort of a bedside decision between you, GI, and surgery, if you're going to do it or not. Medications we'll talk about in a bit. Endoscopy. Most of the papers I read, or the newer papers, say that they should be scoped within 12 hours. So if GI ever gives you pushback, I believe the standard of care is that variceal cases should be scoped within 12 hours. Balloon tamponade, we're going to talk about a little bit more, and then surgery should be involved. And then once the patients are stabilized, you should start talking to invasive radiology about a procedure that's going to offshoot their pressures. So medical management first, obviously, somatostatin is a vasoconstrictor, but it also decreases hepatic pressures. We're more likely to use octreotide, which is synthetic, that works for a longer period of time. Vasopressin also works, and it also has clotting effects, so that's a good one to think about. And then Telapersin is another synthetic that has a longer bioavailable time. I don't even know if we have that here at our hospital. I've never used it before. Once you get in there with endoscopy, there's a couple different things you can do besides identifying the lesions. You can do sclerotherapy, which uses a bunch of different caustic agents. Just realize that for most sclerotherapy, they're not injecting right into the variceal itself. They're injecting into the esophageal wall, and that can have a lot of complications. Right? You can get esophageal scarring, esophageal narrowing down the line. I read one study that a ton of patients got chest pain from it and couldn't tolerate it. Sometimes you can pop the variceal and make it bleed more. So a lot of problems, but they say that banding is a much better thing to do on it. We'll talk about that in a second as well. I read one paper about variceal obturation, which I hadn't even heard of before, where they put skin glue on it. Huge fail rate. I don't think it works that well. I think that's why we never see them use it anymore. It's just fallen out of favor. Just know it exists. When you're doing a scope, always look back. Oh, not you, but make sure that GI people look back at the lower esophageal sphincter and make sure there's no blood coming down to see if they're bleeding actively. This is what banding looks like. They usually put on 2 rows of bands and they stop all the blood flow into the varices. I thought it was actually kind of interesting how they designed the device. What they did is they preload it with 2 rubber bands on the tip, and they put it down the scope, and they put it up to the varice, and then they turn on suction, which pulls the varice into the tube of the device. And then all they do is just slant the tip so the rubber bands roll off and get stuck around the varice and stay on there, hopefully. But you'll see often that they'll miss or they'll fail, and they have to reload and go back in and do it again. Here they're putting in some sclerosing agents. I think this one was ethanol, but you can see how the mucosa is all white and all lacking blood flow. A lot of complications to sclerosing agents. 40% develop chest pain, fever, pleural effusions. Again, esophageal strictures down the line. More bleeding than you started with, always a bad one. And then perforation is probably the worst you can get. I'm guessing that you guys have all heard of the Blakemore tube by now, probably the Minnesota tube as well. We have Blakemores at our institution, but these are double balloon tubes that are the last ditch effort. If you guys have ever seen the GI bleeder who's dying, usually like they have blood pouring out of every hole in their body, their bed is filled with blood, it's running over the sides onto the floor. It's really just a bloody mess. This is the last ditch effort to try and get it to stop. So the Minnesota tube is different from the Blakemore tube in the difference of one port. The Minnesota tube has a port down here where you can suction out whatever's in the esophagus. The Blakemore tube doesn't have that. So you just can take away the risk of aspiration. Anybody that gets one of these tubes really should be intubated already. And if not, you should intubate them before you put it in. So here's how you do it. First of all, you intubate them. And what I'll do is I'll usually put my hand or my 2 fingers into their esophagus, and I'll pass the tube between my fingers, and I'll gently inch it down, because this tube is much softer than an ET tube. It is way harder to get to go down into the stomach. But it's also got a huge big balloon at the bottom, this yellow balloon, that blows up to be the size of a softball. So it's about 4 or 5 inches across. Imagine blowing up that softball in the middle of a varice. That's a really bad idea. So when you're putting in one of these Blakemore tubes, you have to shoot an X-ray after you put the tube in and make sure it's in the stomach. You cannot blow up any of the balloons until you've confirmed it on X-ray that it's in the right place. That's a super important fact about these tubes. So you get it down, you shoot your X-ray, you're in. You're then going to blow up the first balloon, which is the stomach balloon. And this one is blown up by volume. And if I remember right, I think it's either 250 or 300, depending on how big you want it to be. But you blow that balloon up, and then you're going to pull backwards on the tube itself against the lower esophageal sphincter. And what you're trying to do is you're trying to limit blood flow coming from the stomach into the varice. That sometimes helps, or that often helps, decrease blood flow and maybe even stop it. If that fails, then you have to go to the second balloon, which is the esophageal balloon. And that balloon is blown up with pressure. All right, if I remember right, it is 40 millimeters of mercury, I believe. I have it written down later, but I believe it's 40. So the first balloon is volume, and the second balloon is pressure. Oh, 40. Basically, what's happening is the balloon is pushing against the varices and tamponade. And one study showed that as the balloon blows up, once you get above 40, there's really not much of a benefit from it. And if you get up to 75, the esophageal balloon tends to bow outwards and just form like an oval. And it doesn't do much more because only 55 millimeters of mercury are transmitted to the walls, and you can't get higher than that. So there's no reason to go up on that above really 40 where it's effective, just because it doesn't do anything except cause more injury. So for the volume balloon, it's 300. And for the pressure balloon, it's 40 millimeters of mercury. You don't have to memorize these, you're just going to look it up every time anyway, but I put it up there just so you know. Once you have that balloon in place, you want to pull tension on it to stop the blood flow back. You have a question, Mike?
Yeah, just the other services, like required from you that experience, who were they pretty much just.
If I had to guess, I would say GI can do it. Getting a GI guy to come in and see your patient while they're bleeding is always difficult, but once they're there, they probably can do it. My guess is they have a fair amount of experience because they get called for all these variceal bleeders, and that's like the last stage to put it in. So they're probably there by that point. So I would say GI is your best bet to ask questions and to have assistance.
You put one in the ICU.
And I see. Again, because that's where all these guys are gonna end up. They're all super sick and they're all gonna end up in the ICU. So you can tie them to an IV pole to put pressure on it to hold it back. You can also tie water bottles to it, right? They say 500 cc's of water is enough, maybe a liter. But what you do is just gonna tie it to a cling and then hang it over an IV pole. And that's enough force to hold it against the lower esophageal sphincter. And then back in the day, we actually had a football helmet in CCT that you would tie it to. We don't have that anymore, but that's the way they used to do it. They would just clamp it there. They'd pull it real tight and clamp it so it wouldn't retract back against the football helmet's grill. Imagine like one jet bleeder gets the football helmet, then another one gets it, then another one gets it. It was never sterilized. It was crazy. If all else fails, you could try surgical treatment, but most surgeons are not going to want to open up a coagulopathic bleeding patient. It's going to be really tough to get them in there. But what they do is they staple off the lower 5 centimeters of the esophagus and also the upper 2/3 of the stomach. And they try and stop blood flow from going into those varices. Like I said, they're all coagulopathic, so you want to give them a ton of product before surgery takes them. But the last surgery result is liver transplant if they make it through the acute bleed. Invasive radiology also does have a role in this if you can get them there. I won't say fail standard therapy, but they can do PTE or the TIPS procedure to try and off shunt that pressure. And basically what they do is they go into the veins and they put a shunt in from the portal to the hepatic circulation, but doing that bypasses the liver. So now you have a lot of complications because all those products that should be filtered by the liver and taken out are not, and they make it into the systemic circulation. Leads to a lot of altered mental status and a lot of other problems. Right, 20% become encephalopathic, and then 50% their shunt fails within a year. That's a pretty high rate for a risky procedure, but it is last ditch. There's not much left once you've done that. Because remember, 70%, 80% are going to come back with bleeds again. You got to do something, or they're just going to be bad.
I would say if you're putting in the Blakemore tube, it's to get them to a TIPS.
Yeah, without a doubt.
If you're not gonna get them to a TIPS, you're probably no point in doing anything about it.
Gotta be hopeful. So Mallory Weiss tears, self-limited. They're going to pretty much get better on their own. Gastritis and PUD, you give them the GI cocktail. H. pylori, triple therapy. Jebley's foreign bodies, they can be scary and weird. We saw a bunch of them. Varices, probably the worst kind of GI bleed you could get. You don't want to see them. Cirrhosis, portal pressures are very high and they're coagulopathic. Child score tells you life expectancy and periop morbidity, but not too much else, in my opinion. Endoscopy should be within 12 hours. That's a big one. Octreotide and vasopressin for your bleeders. And then the Blakemore tube is a last ditch result, last ditch try. The volume balloon first, then the pressure balloon, after you've confirmed it's in the stomach by x-ray. And TIPS if they survive. I thank you guys for listening. You may not be able to tell, but I had coffee this morning. I apologize for speaking too fast. But I do want to get you guys out of here on time. I'll take away.